So today we address human error in maternity. Now, why does error occur in maternity? We have different ideas of why error occur and why incidents and accidents occur in maternity. But generally, we think of error as acute active failures and then the latent failures that may have led to the errors. So the errors that occur in maternity, or what we call incidents, are the reportable incidents that we have. So the most crucial one that we report mostly is a maternal mortality. But there are certain incidents like postpartum hemorrhage, undiagnosed breech, babies with low ABGA scores, relaparotomies. These are all incidents that occur in maternity. And why do they occur? Normally, you have the proximate agents, the resident on the labor ward floor, the midwife, the senior resident, who is close to the action, who is normally the active participant in that error event. And so we say the active failure or the acute event normally revolves around these people working on the shop floor. But they are not primarily the only agents responsible for this acute event. We have a background of latent failures that may have contributed to these events. And these latent failures may be organizational failures, management decisions, and leadership failures. So the purpose of this whole lecture is to look at how error occurs, the human factor in the errors, and how to address human error in maternity. So how do human error contribute to accidents? I mean, nobody comes to work to deliberately make errors to harm patients. But however, we are often set up to fail by the system. The way our brain works, because we are human, we are not perfect. So being human in itself makes us prone to error. Our training is also sometimes an agent of this error. If people are trained in silos and we don't train as teams, even though we work in teams, then when situations arise that demands that we work in teams, we begin to fail as a team of doctors and midwives or doctors and nurses. Through this, the way equipment is designed and through the way procedures are designed and through organizational culture, sometimes we are just set up for error. Sometimes we also make wrong decisions, even though we are aware of the risk. And I'll come to that later. We don't deliberately make these wrong decisions. We make them as a heuristic, as a way of dealing with situations on the labor ward floor. Sometimes we can misinterpret a situation. However, humans, for most of the time, 9 out of 10 of the time, are agents for good in the labor because we stop disasters from happening, we manage situations, we intervene to reduce the degree of loss. So the human being present on the labor ward is a positive agent. Just that being human and being and not being immune to the physiological processes of being human, we get tired, we get fatigued, we forget, and errors happen. So for an error to occur, there has to be an active failure and there are latent failures. So the active failure is unsafe acts that happens, the mistake, the slip, the forgetting something, not knowing the protocol, doing things slowly, not responding. Those are the active failures that occur. But for an active failure to lead to an error, there would have been a lot of latent failures that would have happened. Improper training, poor equipment, lack of supervision, unsafe supervision, no equipment, all of that will come together to lead to an unsafe situation. Let's take an example of a patient dying from PPH. Active failures that may have occurred is probably poor monitoring. So patient maybe had cesarean section, went to recovery. There was poor monitoring and recovery, and by the time we noticed the patient was in hemoperitoneum, there was just hypotension. Patient has gone into coagulopathy, and therefore patient eventually passed. There was low level of skill in handling the situation. But this active failure, normally you realize that in some units when you go for mortality meeting, we end up berating the staff that the nurses at recovery are not doing a good job, that the residents should have anticipated this. Yes, that's all true. But what are the latent failures? The latent failures for this happening was that there was probably no protocol for PPH in the unit. So everybody manages PPH from what they have read from a textbook. There was no major obstetric hemorrhage protocol. So having no major obstetric hemorrhage protocol means that in the event of we don't even know what level of blood loss that we institute a major hemorrhage protocol in the department, it's not defined. So nobody knows, is it 1 liter, at 1.5 liters, at 2 liters? And when we institute a major hemorrhage protocol, who are we calling? Is it calling to the blood bank? Are we calling anesthetists? Are we calling hematologists? Are we calling consultants, obstetricians? Is there a system to institute the major hemorrhage protocol? If there's nothing like that, then those are the latent failures that probably led to this death. Is there a communication system, or do we rely on people's cell phones to make calls to get people to emergency situations? Was there senior supervision? Is there a means of warming patient during resuscitation? The lethal triad, hypercoagulability, hypothermia, acidosis. Do we have a means of preventing hypothermia in this patient? They just keep getting cold fluids and tons of fluids because there was no protocol to deal with that. Is there group training on postpartum hemorrhage management where the staff overworked on the day? Was there high work pressures? Was there no team training? So these latent failures may have led to the active failure that led to the death of the woman. However, more often than not, we focus on the active failures and forget about the latent failures, and therefore, no matter the number of meetings we have, problems still occur. Now, even with these active failures, we don't assume that staff come to work just to offer poor monitoring. There are certain situations in being human that makes these things happen, and that is what we also want to address in this lecture. What are the causes of human failures? Most of the time, human failures are unintentional. So, unintentional because of execution errors or thinking errors. So, when we think about execution errors, there are certain activities that we do that are skill based that we say we do it from spinal level. We are familiar with the task because it requires little conscious effort. It's these tasks that sometimes we have execution errors with, what we call slips. So a slip can be just doing a cesarean section and forgetting to check the rectus muscle for bleeding before closing up, or doing a cesarean section and forgetting to check what the blood pressures were when you were closing up, because the blood pressures could be very low and you probably don't have hemostasis. So these attention-based slips are often happen because of a lack of attention, because we are doing a whole procedure from spinal level. Sometimes people are waking up at 3 a.m. to do a cesarean section, and it's from spinal level. And therefore, attention-based slips can happen to anybody, no matter your years of experience. Memory-based lapses can also happen to everybody, no matter your years of experience, because we are human and we forget things. We forget to carry out a step in an essential procedure, and therefore a problem may arise out of that. And these execution errors can happen to us because we are human beings. We get distracted, we get fatigued and tired, and we forget things. They're also thinking errors. So these are rule-based or knowledge-based. So we make mistakes either because we are unfamiliar with a situation. So if you've never had to manage hyponatremia in the labor ward and you're presented with it, you're unfamiliar with the situation and you don't know whether you're going to have to restrict fluid in this situation or you're going to have to give fluid in this situation. Or sometimes it's you are familiar with the situation, but the actions that you are carrying out is wrong. So that can be knowledge based. So these often happen with people who lack experience as well. So most of the error that happens is unintentional, and it's either by execution or thinking error. Sometimes the error happens deliberately. So we call them violation or deviations. So violations are often motivated by a desire to carry out a job despite constraints. So most people will not willfully come to work to sabotage a patient or get a patient create morbidity for a patient. It's just because we want to get the work done. And there are three types of violations that we normally face on the labor floor. Routine violations. So when we have routine violations, breaking the rule has become the normal way of working. A common example is people plotting a pantograph after a patient, the lady or the woman has delivered. That is a routine violation because the point of a pantograph is to monitor labor. So if the pantograph is going to be plotted after the patient has delivered, you're just not monitoring the patient. So that's a routine violation, and it happens so often that people accept it as normal and everybody knows they are doing it and it's not addressed. Sometimes you have situational violations where you break the rules because of work pressures or insufficient staff. So you want to just do things quickly, so you skip steps. And then the exceptional situations where you know you need to solve a new problem that has happened that has no solution for. So these are all examples of violations. Now, how do we deal with these human factors? Because we are human, we adapt. We make these errors, we forget. We have attention slips. We have thinking errors, we make mistakes. How do you deal with all of these things? One way is designing for safety. So instead of focusing on people and focusing on errors that people have made, you have to design the environment to make it less possible for errors to be made. So designing for safety is one of the most important things in your labor ward, where you make it impossible for errors to be made and you make it easy for people to do the right things. One of the ways, the fundamental ways to do this is to move away from a blame culture. So in a situation or an environment where blame culture exists, there's always scapegoatism. We are looking for someone to blame. We are fighting over responsibilities. Midwives say this is not our job. Doctors say this is not our job. So there's always a strife in that environment. So the first thing to do is to move away from a blame culture and you move to a just culture. So a just culture is proactive and it's not reactive. It's something we call high reliability organizations, where we say these organizations like aviation, nuclear medicine, and the army are very reliable. And they are reliable because they are proactive, they are intolerant of error. And we have to be proactive as organizations, as labor wards, as maternity units, if we want to be able to reduce the impact of human error on our incidents and accidents. We have to learn to empower staff and abolish a culture of fear in maternity units. We have to get into the culture of reporting errors and reporting mistakes. And that is the only way we can solve problems in maternity. We have to be system focused, and then we have to have high QI standards in maternity. The 5 commitments of a just culture, we ensure there's freedom to speak up and people are not shut down when they try to speak up. We support people when incidents happen. We accept that certain behaviors are unacceptable. Incivility in the workplace, unacceptable. And I'll come to how it affects performance in the workplace. And we always take a systems perspective to problems and design systems that make it easy for people to do the right thing. So let's look at an example of a blame culture and a just culture. Let's say a patient has come in with a retained swab after a vaginal repair or after delivery. Let's look at how a blame culture analyzes this. The first question that everybody asks in a blame culture is who did it? Who did the perineal repair? Who managed it? Who has left the swab in? We said this person is not serious. We need to talk to this person. That is a sign of a blame culture. Normally in a blame culture, the retained swab is not even investigated. All we get interested in is who did it, how to get to that person, how to give that person a dressing down, how to talk to that person. So there's no safety measure put in place to prevent recurrence. The only safety measure is to berate the person who did it. Junior colleagues are warned and berated, and individuals involved are warned and punished. And that is a blame culture. But when you have a just culture, people are not concerned with who did it. We are concerned with why did it happen? Why was a swab retained in our unit? We begin to to support the individuals who were involved, because we know it's a difficult time. Nobody came to the labor ward to intentionally do a repair and leave a swab in. No. So we need to support them and try and understand what may have happened. We put in a system-wide investigation and human factors investigation and try and understand the scenario that led to this. Normally, when you look at a lot of investigations, swabs are left in at handover time when you change from one operator to the other. Swabs are left in at points where staff are very fatigued and doing operations, when units are high activity and are understaffed. So you have to have a system-wide approach as looking at why these events happen. Then you put in measures to prevent recurrence. So you institute a checklist system within your units that after every perineal repair, you have a checklist that two people sign after making a swab count, so that you know that a count has been done. You put a count board in every room to make sure a checklist is done. You put bracelets on patients if you're leaving swabs in. And if you left 2 swabs in, you put 2 bracelets on the patient. And they call it bracelet, purple, red bracelet, so that we know that 2 swabs are in. And when the swabs are removed, the bracelets are out, so that even when the patient moves from one area to the other, these swabs are not forgotten. This is how a just culture investigates, and the lessons are shared widely. So you can see the difference between a just culture and a blame culture, where the focus is on the individual, and in a just culture, the focus is on the system. So there are several ways or examples that will highlight on how to reduce human errors in our environment. One of them is a surgical safety checklist. So before you do any surgery, you have a safety brief. And I'll come to a safety brief later on, where you talk about the patient. And at this safety brief, you have your anesthetist, you have your midwife, you invite your pediatricians. If you think a baby will need resuscitation, you have your theater staff. You talk about the patient you are going to operate on. You talk about their allergies, you talk about their weights, BMI, you talk about what you need for surgery and equipment, so that you're prepared for the surgery. And everybody has the same mental model going into theater. You don't get to theater and get upset in theater because you don't have a head elevator, because you didn't anticipate it going into theater. You didn't talk about it. You don't give a drug when the patient is allergic to it, because you've discussed it. And then you also do your swab counts. Because we are human, we are prone to error. So if we institute a means of reducing this error, like a checklist swab count, we do 1 swab count at the closure of the uterus, 1 swab count at the closure of the fascia, and a swab count when we are closing skin. Know that with these 3 swab counts, the chances that we will leave swabs in is really, really low. And that is a system approach to dealing with the human influence, because human beings can get tired, can get fatigued, and leave swabs in. And it's human. It can happen to any one of us at any time. Have you ever done an instrumental delivery without emptying the bladder, without being sure of the fetal position? So these are safety issues, and it can happen. And having a checklist in place before you do an instrumental delivery reminds you that you need to be sure of the fetal position before you place your cup or before you place your forceps. You need to empty the bladder before you proceed. So these checklists, you need to do a swab count before, you need to do a swab count after, so that you don't leave swabs in. And you need 2 people to sign to show that you've done a swab count. And the checklist will remind you if you've left any pack in or any tampons in. So these checklists are supposed to help you to reduce error in patient management. We also have to remove stresses from the work environment, because stresses in the work environment reduce patient performance. So if you have an overcrowded labor ward, for instance, or a crowded delivery suite, you immediately reduce staff performance. So these are things that as leaders in healthcare, we have to help to streamline, to improve staff performance and reduce error in healthcare. Have you ever tried to do a perineal repair on a bed without stirrups? This is an error-prone situation. It's a very difficult repair, and therefore you're setting people up for failure, setting them up for frustration, bad repair, chances of leaving a tampon in, chances of wound breakdown increase just because of equipment. So why will we make it? Let's make it easier for people to do the right thing. Imagine a patient who needs to be continuously monitored. If you're asking staff on a busy unit to be checking the blood pressure with a mechanical mercury sphygmomanometer, the chances that it will not be done is really, really high, as against putting them on a monitor and automating it. You may not get exact values that you want, but automating it means that the blood pressures will be monitored. And so, again, ergonomics, making it easier for people to do the right thing. Do you have a unit where, compare a unit where you have to call somebody in an obscure corner to come and do an ECG versus a unit that has an ECG machine sitting there and all staff know how to do an ECG? The chances that a patient with chest pain will be saved is higher in a unit where doctors can just feel the ECG, put the probes on and do it. So just make it easier for us to save patients. You have a sepsis 6 protocol, but your culture bottles are sitting in a private lab. You know that blood cultures will not be done before antibiotics within the golden hour. So again, if you want things to be done, you have to design a system to make it easier for people to do the right thing, because nobody comes to work to do the wrong things. Nobody comes to work to harm patients. But if we put impediments in people's way to do the right things, patients end up getting harmed. Because we are human beings, we say we cannot keep 7 ideas in our heads at a time. And therefore, having a labor ward board with all the activity going on in the labor ward itemized on it gives situational awareness and gives staff a helicopter view of what is happening, who is on the labor suite, who needs to be examined next, when do they need to be examined, who is going to theater, in what order are we going to theater. Having that helicopter view gives people situational awareness on the labor ward. Not having that is a safety risk, because we are human beings. We cannot store the memories inside, the information inside different patient notes, and we need to summarize this in a graphic way. And this is a safety tool. So make it easier for people to do the right things. Make it easier for humans to function in the environment by putting prompts within the environment. Again, we know that human performance decreases after 12 hours, and the time that we make the most error is between 2 and 5 a.m. in the morning. And therefore, if you are running a 24-hour shift, you should know that ab initio, after 12 hours of performance will decline, and you have a lot of your errors at dawn, because people will frankly be tired, and therefore you have to streamline your work processes to make sure it is safe. So these are all ways of looking at human factors, how human physiology performs, and implement it into your labor ward practice to make sure the practice is safe. So I've already spoken about safety hurdles, discussing cases before you start in theater to improve safety. Civility in the workplace. We know that incivility and strife and rudeness reduces performance drastically. If you have a polite surgeon, anesthetist performance is at 91%, but it slips to 63% if you have a rude surgeon. So again, creating an atmosphere with a just civil culture immediately improves performance and reduces error. Rudeness in a surgical setting increases staff sick day, decreases attention and helpfulness, increases error. So these are all signs. And therefore, as leaders, we need to not just look at the textbook, but we have to look at the system holistically in order to reduce error in maternity. So in summary, what I need to emphasize is moving away from the blame culture to a just culture. Leaders having a systemic thinking, and with effective leadership, we can institute change and reduce error in maternity. Thank you.